Hello, I'm Shail Gavani from the University of Michigan, and on behalf of my co-authors, I'd like to tell you a bit about our paper studying models of CT outcomes in patients with Crohn's disease presenting in the emergency department. CT is both a useful and sensitive test in the detection of complications and inflammation in Crohn's patients. However, the dose delivered per CAT scan can be high, with an average of 16 millisieverts per scan. We know from Hiroshima that doses greater than 50 millisieverts are associated with an increased risk of malignancy. Unfortunately, our patients receive this type of dosing frequently, with more than 10% of patients receiving more than 50 millisieverts per decade. So we hypothesized that patients presenting to the emergency department could be risk stratified based upon labs alone to determine who needs a CAT scan. We aimed to model both complications and inflammation separately, and the goal was to obtain models which were highly accurate as well as a model which had a high negative predictive value. This way, providers feel comfortable not scanning patients. We did a retrospective review of Crohn's disease patients presenting in the emergency department between 2000 and 2011, looking for those who had a CAT scan with contrast within 24 hours of arrival. We used labs that were obtained within 24 hours of arrival for our models. Inflammation was defined as thickening with stranding and/or mucosal enhancement. Complications was defined as a new perforation, abscess, or another serious finding. We also termed this as PA+. We did not model obstruction. So we reviewed almost 2,900 charts for 1,200 individuals and excluded those who did not have Crohn's disease, those who did not undergo a CAT scan within 24 hours of arrival with contrast, and those who presented for traumatic complaints. After exclusion, this yielded about 1,100 visits for 613 individuals. Of these visits, 16.8% had complications and 54.5% had inflammation on their CT scan. One patient had 31 CAT scans. So we created models using logistic regression and SAS. We looked for lab predictors that were significant in a univariate analysis with a p-value less than 0.05. We then used the best subset selection method with complete case analysis to pick our models, so no imputation was done with missing lab values. Our models were then tested using tenfold cross-validation. Here we have the ROC curve for our complications model. The area under the curve is 0.8. At a 6% predictive probability, the negative predictive value was 98.1%. The model consisted only of ESR and CRP. Looking at the classification table in the bottom right corner, you'll see that 211 out of 491 patients could have been saved from CAT scanning. This is a save rate of 43%. Here's the RC curve for our inflammation model. The area under the curve is 0.68. At an 8% predictive probability cutoff, the negative predictive value is 93.3% for inflammation. This model consists of a number of labs that are easily obtained.
So the conclusions of this paper, first, that complications were very well predicted. If you implement this, you could reduce the rate of CT scan by about 43%. And even with that reduction, by avoiding scanning very high-risk patients, you would only miss complications in 4 out of 491 patients, or 0.8%. We also found that inflammation was very well predicted. We might be able to build a better model if sedimentation rate and CRP were measured in all the patients rather than just the 50% in this study. And you might be able to detect inflammation better if you regularly use CT enterography, which was only used in about 15% of the patients in this study. We also found that obstruction was not able to be modeled with the variables we had available in this study. We currently have an external validation study ongoing with the collaborators at the University of Pittsburgh to determine the external validity of this algorithm. The implications of this study include cancer reduction and cost reduction. In terms of cancer reduction, we estimate that there are about 540,000 Crohn's disease patients in the United States. We believe that about 2 CT scans are done per decade on average in Crohn's disease patients. Based on the Hiroshima data, if you do 1,000 CTs in a 40-year-old patient, you get 1 additional attributable cancer. If you extrapolate from this and are able to look at all the cancers in all Crohn's disease patients in the US, that means an additional 1,080 cancers are caused by CT scans done in the emergency rooms in the US. If we reduced our use of CT scans in the emergency room in Crohn's disease patients by 40% over a decade, we would prevent 432 additional attributable cancers. In terms of cost reduction, if you assume that the Medicare rate of $350 per CT scan is used, we could reduce our costs by 40%, or based on Crohn's disease CT scan rates in the emergency room in the U.S., by $150 million over one decade. I'd like to acknowledge our co-authors, Dr. Amanda Guttner, Dr. Akbar Walji, and our lead author, Dr. Shail Gavani. I'd like to thank the IBD Working Group and UCB who funded this study, and our video producers, Dr. Ryan Stidham and Claire Higgins.